Okay. Hello, everyone. I'm glad you can make it to tonight's presentation. Feel free to let us know where you are from by writing in the chat. Tell us what city you are from, and you can even let us know why you wanted to join this virtual conference. Tonight's session is Options in Pain Management, and I am the director of I am the Chief Science Officer for the Marfan Foundation. I'm delighted to introduce to you Dr. Tracy Speed from Johns Hopkins School of Medicine. She is an assistant professor of psychiatry and behavioral sciences. She specializes in the management of patients with comorbid chronic pain and psychiatric disorders, with a focus on patients with connective tissue disorders. She's an attending psychiatrist of the Johns Hopkins Pain Treatment Program and the Food, Mind, and Body Clinic, as well as the chief psychiatrist of the Johns Hopkins Perioperative Pain Program. So during the presentation, if you have any questions, you can put them in the Q&A box, and we will try to get your questions answered at the end of the presentation. If your questions are not answered, please post them at marfan.org/ask, and we can try to get them answered after at a later time. So Dr. Speed, again, thank you for joining us today, and you can share your screen.
Great. Thank you for the introduction, Joe. We get it?
Yes, it looks good.
Great. Well, thank you again for the introduction. Thank you for the opportunity to speak. I'm excited that this is a virtual format to increase access to some of these topics, but I really do enjoy meeting everyone at the conference every year too. So I'm going to be talking about options for pain management. And I am coming from the perspective of a psychiatrist, but I'm going to talk broadly about some different treatment approaches. So pain is made up of two parts. It's both a sensory experience that's associated with some type of physical change, and it's an emotional response of distress and anxiety to that sensory input from the physical manipulation. And I like to start with this picture by the famous artist Frida Kahlo, who suffered from pain from both polio and then being in a bus accident requiring a lot of surgeries, because I think she really depicts how complex and disabling chronic pain can be. So there's a difference between acute and chronic pain, and acute pain management has different treatment options. For the focus of this talk, we're going to be talking about chronic pain. And when I use that term, it can mean two different things. It can be the result of some type of ongoing acute injury, so some type of malignancy, tissue destruction, or kind of bone deformation, or some type of chronic infection. It can also be the result of an adaptation of our nervous system to injury. And that means that there might be some type of initial injury, like a burn or breaking a bone or something, but then even when the body heals, the pain continues and doesn't resolve. And you can think about chronic pain as kind of occurring in there's three different ways we can classify chronic pain. So first of all, there's been that expression, the pain's all in your head. And I do want to clarify that pain is in your head. In fact, our peripheral nervous system and our central nervous system, or our brain, are interpreting pain and trying to protect us and warn us of danger. And so if there is a type of injury, let's say to the knee, you can see the red line is the nerve that goes up through the spinal cord, going through the back of the spinal cord closest to our actual back, and then goes up to our brain through a sensory processing system, as well as through our emotional processing system, and goes to our cortex. And then those communications will end up going back down. And the blue line actually represents this pathway called descending pain modulation, meaning that our body is actually able to kind of block pain as well. So before I started this talk, someone who might have chronic pain might not have noticed that their knee was hurting them. But now that I've mentioned it, the red pathway up to your brain has been activated, and perhaps the blue line has stopped working, or that descending modulation. So when we talk about a type of neuropathic pain, oftentimes that means that one of these nerves in this pathway has actually been damaged. Sometimes pain can also continue and be chronic because our autonomic nervous system has been activated and continuously turned on. So our autonomic nervous system is a combination of our sympathetic nervous system and our parasympathetic nervous system. And we talk about the fight or flight response, or rest and digest. And the fight or flight response is an evolutionary advantage, right? To be able to run away from the lion when the lion is attacking. And so what do we need to do that? So our heart rate is going to go up, our eyes are going to dilate, our lungs are going to be able to take in more oxygen. And the things that we don't need to be able to run away from that lion, like having a bowel movement, those systems shut down. Because the autonomic nervous system, which is actually the tracks on each side of the spinal cord going down, because those little cell bodies are so intertwined with our central and peripheral nervous system, they can get overactivated in chronic pain. And some of the symptoms to be aware of might be that someone who's sweating a lot, their hands are cold because the blood isn't flowing to their hands, rates of dizziness, nausea, difficulty tolerating the heat, constipation, difficulty sleeping, and restless legs. So when all of those symptoms plus others are happening together, we want to think about maybe the autonomic nervous system is helping to drive chronic pain. Another pathway is something we now call central sensitization. And that means that those nerves that transfer from our peripheral system to our brain, some of the cells in our brain that detect pain and the emotional response to pain get just turned on actively. And so the brain is unable to tune out that, what I like to call noise, and we're more sensitive to pain. And we can actually see from imaging of the brain, where we put someone who doesn't have that kind of chronic pain or central sensitization compared to someone who does, that there's more areas of the brain that light up in someone who's experiencing central sensitization. So those are some of the main pathways, but at a more molecular level, we have a greater understanding of what's driving chronic pain. And it's actually very complex. So this image is a representation of different cells communicating with each other. It could be in the peripheral nervous system, or it could be in the central nervous system. And you can see that there's many pathways that are affected and regulating our pain modulation, or how our body interprets pain. And so there are certain chemicals like dopamine and norepinephrine that regulate our mood and our ability to enjoy things and our executive functioning, and our autonomic nervous system that also regulate pain. There are electrolytes like sodium and calcium and potassium that activate action potentials through our nerves and can tell us that we're constantly in pain. And then there are different receptors like NMDA, GABA receptors, our endogenous opioid and cannabinoid systems. And we now know that the nerves have their own kind of inflammatory system, specifically microglia, that can activate the pain receptors and pain nerves. So throughout the talk, I'll talk about how we can use these approaches to help modulate and reduce pain. So going to Marfan syndrome and other connective tissue disorders. So this is some research that I've done in 2017 now, as well as another group out in Chicago, which was some of the more recent research to help characterize chronic pain in Marfan syndrome. And overall, the literature shows through different surveys of people responding who had a history of Marfan syndrome, is that pain is nearly ubiquitous. So at least from this survey report, 89% of people talked about having some type of common pain. And most often pain is occurring in the back, but it can also occur at many other joints, the shoulders, the knees, the hips, the legs, the feet, right? And people also are experiencing pain in their chest and their abdomen. So it can be happening anywhere throughout the body. And typically people report pain on a scale of 0 to 10, somewhere that rates as moderate pain, but we know that people can also have pain flares where they can have really intense, severe pain. And so in some of the research that I showed in 2017, the respondents of our survey, over 2/3 said that they experienced pain over 50% of the time. Over 3/4 said that their pain can be horrible or excruciating at its worst. Most people have pain flares or increases in their pain compared to their baseline. And 70% said that they had no relief from their pain, meaning it was always there, constant. And despite the excruciatingly high number of people who had pain, almost half of them hadn't ever had a formal pain disorder diagnosis. So a diagnosis for chronic pain is really important because chronic pain is a very disabling condition, right? Someone who's experiencing pain can be really demoralized by the pain. They can start to lose interest in things because pain affects our dopamine, which is the neurochemical in our brain that makes us say, yeah. It affects our sleep. It causes us to be more fatigued and to lose interest in things. And over time, that can lead to increased disability, isolation, substance use, feeling hopeless, engaging in more dangerous or risky behaviors to try to cope with the pain, and then sometimes even kind of losing some faith in the healthcare system and maybe not adhering to treatment. And with all that said, we know that pain affects our quality of life. So when we're experiencing chronic pain, it can affect our relationships, our ability to perform at school or work. Chronic pain certainly depletes energy and causes a lot of fatigue, as I mentioned earlier, and it makes it harder to do social activities and sports, and also affects our physical and mental health. So going back to pain specifically in Marfan syndrome, we had found that 89% of survey respondents reported some type of pain. And among respondents who had pain, over 1/4 of them said that pain was actually one of the first symptoms that led to their Marfan diagnosis. And for 44% of respondents, they said that their pain had spread from one initial site in their body to more than one site as well. And so we compared what that meant in terms of their functioning and quality of life. And you can see that compared to people who had no pain, which is the very light orange color, people who have some type of pain, they had worse pain disability, higher pain catastrophizing, which is a measure of cognitive worrying and feeling helpless about pain. They had poor physical health and lower mental health. And then people who had earlier onset of pain and who experienced pain spreading similarly had greater pain disability, greater pain catastrophizing, and worse physical and mental health as well. So this tells us that the earlier the pain, probably kind of the worse it is and the more it's complicating life. So what type of treatments are individuals with Marfan syndrome using? So a survey of over 990 patients showed that most people are using some type of pain medication within the past week of completing this particular survey. Many people are using over-the-counters like non-steroidal anti-inflammatories or acetaminophen. And some people, about 1/3 of patients, were using some type of analgesic or pain medicine daily. Medications were more frequently used, but non-medication or non-pharmacological therapies are also very common. So many people had tried physical therapy or massage, and then warm compresses or heat and relaxation techniques have been commonly tried among individuals with Marfan syndrome. As I mentioned, medications are very common. And so we had asked in a survey about if people were using these types of substances. Again, looking at a survey of 200+ respondents, most people were using some type of over-the-counter on a regular basis for pain, and fewer people were using kind of herbal supplements or any type of occupational or pain interventions from a psychological perspective. In this study, we also looked at opioid use, and now this study was done about 2017, so it was around the time that the CDC had reported guidelines that chronic opioid use was not effective for pain, but that kind of the transition in our country of tapering people off opioids probably wasn't happening yet. And you can see that individuals who reported that they were using opioids for pain had significantly more constant pain, more pain severity, more pain interference. They were more likely to have those pain flares, less likely to have pain remission, and more likely to have pain as their presenting symptom for Marfan. And so this was just a cross-sectional analysis, so it doesn't give us any type of causation. But looking at this data comparable to the kind of chronic pain literature in general, we know that people who have more comorbidities or more mental health conditions are more likely to end up on opioids, as well as those reporting chronic pain. It's also likely that the opioids might not be as effective for pain as some had hoped. So as I mentioned, there was a publication in 2015 and then the CDC guidelines showing that opioid use is not as effective for chronic pain. And this has significantly impacted kind of our opioid management across the country because for years, opioids were the first line treatment for pain. And because of the opioid crisis that our country is in terms of opioid overdose deaths, obviously there's been a big shift in trying to take people off opioids. And what I'd like to do is make sure we're talking about other strategies or ways to manage pain when opioids aren't as effective or when it's harder to get. Now, one important point is that the pendulum tends to swing one way or another. And while opioids might not always be effective for chronic pain, that doesn't mean that some people can't benefit from them and that they can't help people function and get to work or get to school or do certain things. So as I mentioned earlier, chronic pain is really complex. There's a lot of mechanism driving chronic pain. And so where do we start? How do we help individuals who are experiencing chronic pain? Well, first, it's important to know that there are a lot of chronic pain specialists. Not enough, certainly not enough in our country, but there are many. Unfortunately, our healthcare system is broken and it's siloed, and it can be really hard to find the appropriate treatment providers. But what I encourage my patients to do is to look for a quarterback, someone who's going to be kind of the prime person that they're going to communicate with and who can talk with their different other providers. And I try to find a very neutral football team here, so you can insert who you want or what your favorite team is. But that's kind of what you want to find is providers that you trust and you believe in and who are going to work with you and make sure that you're engaged in treatments. So I'm a psychiatrist, so I think that psychiatry can play a very significant and helpful role in chronic pain. But for behavioral health in general, most pain specialists are going to be psychologists, meaning they have a PhD and they're doing different types of behavioral or psychotherapies. Interventional pain doctors are the most prevalent across the country. Usually they're trained in anesthesia, and they're the ones that are oftentimes doing procedures, different types of injections, and they can also prescribe medications. Another pain specialty is called physiatry, or physical medicine and rehabilitation. This is a subspecialty of medicine of providers who are trained in rehabilitation, especially regarding kind of brain injury, spinal cord injury, musculoskeletal injury. And I suspect that they're really underutilized for pain, and highly recommend thinking about finding a local physiatrist. Then there's integrative medicine, which was formerly called complementary and alternative medicine. Integrative medicine can include massage, hypnosis, acupuncture. And while the literature isn't as in depth in terms of the benefits of pain, there are certain individuals that can really benefit from those types of treatment modalities. And lastly, there's different types of therapists. In particular, there's occupational therapy or physical therapy. I always encourage my patients when they're looking for a physical therapist to kind of interview that therapist and make sure that they can appreciate that this is chronic pain. Many physical therapists specialize in helping recovery after like breaking a bone or some type of acute injury, but there are definitely therapists who are trained in managing more chronic pain conditions. So what's the goal of a clinical assessment? Well, the first is needing to have a diagnosis. In medicine, we learn that you need to have a diagnosis in order to treat something. So that should be the first thing that a provider is doing, is being able to identify and treat the underlying cause of pain. And then we want to think about all the other things that are affecting pain and the quality of life. And so those are the kind of comorbid or co-occurring conditions. And those many of them are psychiatric or behavioral, such as depression, anxiety, sleep problems, substance use problems, etc. You want to think about the psychosocial factors that are affecting pain, right? What types of levels of stress, someone's home environment, their interpersonal relationships with their family or friends, what type of work they have, and then obviously how they're functioning, because this is really the key for pain management. It's about helping people function. And so what are their baseline activity levels? And in terms of a formulation for the other factors that are affecting pain, you really want to think about the whole person. So who is this person? What are they dealing with? What's happening in their life? And what other kind of co-occurring conditions are happening? And I mentioned a lot of psychiatric conditions because, again, I'm a psychiatrist, and just like a surgeon's going to want to perform surgery, I want to be able to treat the underlying disorders that could be affecting pain. But also because these conditions are so highly comorbid in chronic pain. So things like depression and anxiety, about 30 to 60% of individuals with chronic pain are going to have some type of depression. And we know that these types of disorders can make it more difficult to recover. So it's important to be able to identify and treat these disorders. So when I think of the goals of pain management, I'll tell my patients that we can't make the pain go away completely. So the goal is not to eliminate the pain, but it's to kind of put it in the background so that you're not thinking about it all the time. And we're going to try to diminish the pain because we're going to help to recondition the muscles and help with rehabilitation. From my perspective, a goal is functioning, giving someone back a better quality of life. And then we're also trying to decrease the things that us professionals and providers and doctors do that can sometimes actually harm or worsen pain. And once you find that provider who's going to be your quarterback or who's going to be one of your specialists, it can be helpful to develop a targeted treatment plan. So many of you might be familiar with different goal setting techniques like SMART goals, and that includes finding very specific measurable goals, things that you can achieve that are relevant to your day-to-day and oftentimes have some certain type of time. And so sometimes when I see a patient, it's talking about, okay, we're going to have you shower once or twice a week, right? Or we're going to have you walk to the mailbox first. So there are things that are achievable so that we can build and someone doesn't get demoralized by trying to overachieve something that they're not really ready to do yet. In order to meet these goals, we need a therapeutic strategy. And there are multiple ways to be able to manage pain. So earlier I mentioned that individuals with Marfan syndrome report taking medications, and using different approaches like physical therapy. And there's other rehabilitation approaches like different exercise treatment programs or using assistive devices. There's interventional pain approaches like injections or stimulators. And then of course, there's different psychological treatments, whether that's a different type of therapy or even group or family therapy. And again, the integrative treatments, things like massage, acupuncture, hypnosis. When thinking about medicines, for chronic pain, it really is what we now call a multimodal treatment approach. And so that means that when you look at the nerve and all the different ways in our body that pain can be processed and can become chronic, there's so many pathways. So oftentimes we actually need to use more than one medication to be able to tune down those pain pathways and block the noise of the pain. So some of the medications, and I'll go into this in a few slides down the road, is using different types of antidepressants, again, the over-the-counters like acetaminophen, different anti-seizure medicines, which are also slowing the nerves down, as well as things that can target our inflammatory processes. So when I think about medications, I think of them as neuromodulators because over time, if you're using medications that are changing the signaling between nerves, we know that our nerves are actually plastic, meaning that they can form new connections and they can grow. And so you're able to help modulate the nerves. And so the most common medications that are used for chronic pain are things that tend to also be psychiatric medications or psychotropics. And these are tricyclic antidepressants, SNRIs, so serotonin, norepinephrine reuptake inhibitors. There are some atypical antidepressants, things like mirtazapine. Many of the anti-seizure medicines like Depakote or lamotrigine or gabapentin or pregabalin. There's other medications that, because they're targeting your serotonin and norepinephrine and dopamine, they can help augment and boost the effects of the above medications. And so there's things like olanzapine or lurasidone that can be helpful. And something that's slightly newer relative to those other medicines are medications that target our inflammatory system in our nervous system or the microglia. And so some of you might be familiar with low dose naltrexone. Naltrexone is an opioid antagonist, but at lower doses, it actually targets our microglia and doesn't interact with the opioid receptors. And so there's some evidence that this medication can be helpful for chronic pain. So we're going to next talk about a lot of different non-pharmacologic or non-medicine treatment approaches. I will say that when I'm thinking about helping a patient through chronic pain, there's some different approaches that we're going to think about. And the first is that this pain might actually get worse before it gets better, right? Someone who might not be engaged in physical therapy or might not be very active, that process of reconditioning is really hard initially. So that pain might be more severe, but you're making short-term pains for long-term gains. And that managing chronic pain is a commitment, right? If you've been experiencing chronic pain for years, it's going to take several weeks to months to really start to see a change. So it really is a commitment to the process. And so just like many other things in life, if you have a bad day or you slip one day, that's okay, because we're going to kind of do this over months or years. Earlier before I said to set short-term SMART goals, but we also want to think about the future and what the long-term goals are. Like why are we working so hard on rehabilitation? And then again, there's expectations that we can, once chronic pain is there, we can never make it go away completely, but we can help reduce it and turn down that noise and make it possible so that someone can still really enjoy their life and engage in activities that bring them joy. So rehabilitation can involve a number of different things. It can involve working on building up interactions with family, re-engaging with work or social activities. Sometimes it involves different type of environmental changes. There are sometimes we develop triggers or things that really upset us in our current environment. And so it's finding other things. It's one, recognizing those and then finding other situations where we can find comfort. When I say extinguish the habit, I'm usually referring to some type of substance use. So sometimes we turn towards alcohol or other substances that can help calm us, but over time they can actually worsen our pain or make us kind of feel numb, and that might not actually be as helpful in recovery. Thinking about new treatment approaches, when the things that haven't been working, when they're not working, we need to try something new. So what are the new options? And then again, thinking about what are the other motivators in terms of work or education that can improve quality of life. And in order to accomplish these goals, we can really build a toolbox, so different treatment approaches. And from a psychological perspective, there are a number of behavioral approaches. I'm going to kind of talk about each of these in terms of relaxation, imagery, distraction techniques as well. And I'll oftentimes guide my patients to say, we're going to build this armamentarium, right, of tools, because one day you might find one tool helpful and the next day you might end up needing a different tool. So it's good to have a wide variety of options. The nice thing about different behavioral approaches for pain is that they tend to be really helpful for other things too, like anxiety, depression, specific types of pain, and different stressors in our lives. And the gold standard for pain behavioral therapy is something called cognitive behavioral therapy, or CBT. And this is based on the idea that how we think and how we behave and how we feel, they're all intertwined and the arrows are going in all directions. So they all affect and interact with each other. And oftentimes we tend to make decisions because we feel a certain way and we let our feelings guide us and let our feelings kind of run the show. And we're not always going to do a certain thing. But so CBT kind of flips the arrow and says, why don't we start doing things? And the more you do things, after a while, you're going to start to feel a little bit better. And so this is a well-studied, robust treatment response that's been shown to be effective for pain, as well as anxiety and depression. And from that, there's been other treatment modalities that have kind of become the second and third wave of therapy. So a more common one you might have heard of is something called acceptance and commitment therapy. And this is based on accepting our life circumstances and still committing to the process of getting better and finding different activities that reflect our values and again, bring us joy. There's also a newer therapy, something called MORE, which is a mindfulness-oriented recovery enhancement. And so this treatment was created by Eric Garland, who's based out of Utah. And he's been able to show that if you combine a mindfulness therapy as well as something called savoring, which is the ability to attend or engage in more pleasant experiences, that can help and boost mood. And the nice thing about this treatment strategy is that he's been studying it in individuals who have chronic pain, who are also experiencing depression. And for some people, they're also experiencing substance use, and has been able to show that even if you have all of these kind of co-occurring conditions, that this type of treatment can still be really effective. There's also a number of relaxation techniques. So we'll talk about guided imagery, some mindfulness, biofeedback, deep breathing, and progressive muscle relaxation. So guided imagery is an idea to consciously produce the body state of relaxation. So it involves a process where we can help our body we can slow our breathing, we can help lower our blood pressure, and it can help us feel calm as well through kind of imagining that we are on a different journey or kind of visualizing a different technique. And there's a lot of different videos online where you can engage in this type of guided imagery, or your therapist can do it with you as well. Many people have heard of mindfulness and think about meditation, and that is a component of mindfulness, but a mindfulness-based stress reduction is a way to kind of be more present and do that in a non-judgmental way. And there's a lot of evidence that this type of treatment can be helpful for pain. It can actually reduce inflammation throughout our body, and it can change some of the neurochemistry as well, and it can improve our sleep. And can really be neuroprotective for us. Now, one of the keys is to find experts who have been trained in mindfulness, but to also realize that any of these therapies, you want to practice during a time when you're not experiencing a lot of pain or not experiencing a lot of stress. So if you think about if you are engaged in an activity when you were younger at school, whether it was a sport or some type of like studying for a test or preparing for an exam, it's easier to learn new skills and to be able to kind of memorize or get into a routine when you're not quite as stressed, right? So, and this is the same for practicing these relaxation techniques. So biofeedback is something that is sometimes harder to get around a country, but there are different certification programs and ways that you can look up and see if there's biofeedback available in your state or in your town. And what it is a process that enables us to actually change our physiological activity. So earlier I mentioned how we have an autonomic or that fight or flight system. And those things, that's our heart rate, our blood pressure, right? Our breathing. Those are things we do all the time and we don't have to think about it. Our body does it automatically for us. But if we actually start to think about those experiences and how our body's performing, we can have some control, and that can help lead to some relaxation. So there are actually instruments that you can apply to your body, and it can measure either your brain waves, your heartbeat, the rate of your breathing, your skin temperature through skin conductance, and then your muscle activity. And as you practice relaxation and see that you can slow down your heart rate or slow down your breathing, that gives you an immediate feedback to realize that you're helping reduce stress through your body. Similarly, there is just deep breathing. There's different techniques to be able to sit up and slowly breathe through your nose and to be able to feel the air actually expanding in and out of your chest. And to do that repeatedly. This is something can be helpful to do with a therapist initially, but there's also, again, lots of videos online to be able to practice and gain these skills. And then one of my favorite techniques is something called progressive muscle relaxation. And that involves tensing and relaxing muscle groups one by one throughout the body. And so usually you start with the feet and you kind of squeeze the feet and recognize that tense sensation, do that for 10 seconds and then release and take a deep breath. And then you continue to squeeze muscle groups throughout the body up until you get to your head. The reason I like it is because the idea is that you're actually showing your body what it feels like to be tense and what it feels like to be relaxed. And it also is something that you can physically feel that change really quickly. Sometimes patients, especially with connective tissue, say, well, this part of my body is so tight, or it doesn't help me to realize that that's tense. And you can skip certain parts of the body. You don't always have to go up everything. So if you want to start with your legs or maybe not progress all the way to your shoulders, you can modify these techniques to help you. And then there's something called cognitive behavioral therapy for insomnia. So this kind of goes back to what I was talking about earlier with cognitive behavioral therapy, but this is actually specifically for sleep. So I didn't get into it too much in this talk, but we know that the interaction of pain and sleep, that it's a bidirectional relationship where both affect each other. And so individuals with chronic pain tend to have really poor sleep. And then that poor sleep ends up worsening chronic pain. And it becomes this vicious cycle that goes on and on. And some of my colleagues at Johns Hopkins have been able to show that cognitive behavioral therapy for insomnia, where you're focusing on improving the quality and quantity of your sleep, can actually reduce pain. And one of the helpful apps is something called CBTI Coach. It's a free app. It was developed by the VA with Stanford University. I have no affiliation with the app nor with either of those institutions, but it is designed to be used as an adjunct or with psychotherapy, but also realizing that most people don't have access to sleep experts. So it is designed so you can use the tool by yourself in order to learn more about sleep and then modify sleep behaviors. What I really like about the app and why I suggest it to so many patients, in addition to being free, is that it actually includes all these different techniques of relaxation and guided imagery and progressive muscle relaxation and body scans in one app. So you can get all of this for free in one location, which I think is really great. So overall, I've talked about a lot of different strategies, and I've kind of leaned into this idea that what we're trying to do with chronic pain is really help with functioning. And so we're looking for ways to heal and to find treatments. And overall, we want to find ways to enjoy life, right? So through building social connections and social relationships, thinking about job opportunities, different relationships, feeling secure financially, and really learning to appreciate and acknowledge and even love ourselves. And so these things, as we're starting to feel better and starting to manage pain, these are the types of reinforcers that give us this kind of positive response and can lead to ongoing commitment to the process of managing chronic pain. So I'm going to end with a few thoughts and save a lot of time for questions. But every individual, their pain experience is very unique. Overall, we want to think about structure, hope, and then advocacy for pain. Chronic pain is so debilitating and can be really hard to manage. And so we want to accept the little victories when we have them. And overall, I view us as we're trying to improve functioning in spite of having pain. And so with that, I'm going to open up to questions. I do realize that I didn't focus on a lot of the spine stimulator or different interventional procedures, but happy to kind of answer those questions as best I can as well.
Thank you so much, Dr. Speed. We have a few questions that came in, so let me start with one that I think you have a lot of knowledge in. Can you give any recommendations for approaching chronic pain management in patients with a history of substance disorder?
Sure. I think that's really important. So as I mentioned before, our medical system is really siloed, and everyone wants to kind of treat their specialty. We've all become subspecialists. So someone can treat the pinky finger on the right side and someone will treat the pinky finger on the left side. But to get to that question is, unfortunately, with kind of substance use and pain, you can oftentimes find these situations where someone in substance use says, well, I can't manage chronic pain. And someone in chronic pain says, we have substance use, so you shouldn't kind of come to our clinic. And I think that if you can, you want to find a place where there might be what we call like a stepped care approach, where there are substance abuse providers talking with chronic pain providers and working together. If anyone has access to the VA, they've become really the best model of that treatment. A lot of psychiatrists are going to have experience and training in both, and a lot of the techniques in terms of pain management and these therapies can be helpful. So engaging in these different treatment approaches can be helpful. And then a lot of the medications that can help with pain can also sometimes reduce cravings or help with substance use. So there are different antidepressants or seizure medications that can boost mood and then can help with depression, substance use, and chronic pain as well. So sometimes you have to kind of cycle through different strategies. But what I would say is don't give up in terms of trying to find providers who are willing to at least talk and communicate with people in the other silo.
Great, thank you. For autonomic pain, could you have some but not the others of those symptoms? For example, I'm often dizzy and fatigued and have cold hands, but I very rarely sweat.
Yeah, so I kind of gave the group of symptoms that can all happen together, but that's not necessarily, you don't have to have all of them, right? So just like if you have a head cold, you might have a runny nose or a fever and some chills, but you might not have that cough, right? But you still have an upper respiratory infection. And so what I would suggest is if you tend to have some of those symptoms that I was mentioning, it can be helpful to talk to your provider about a chance that maybe your autonomic system is overactive. And some of the common terminology is called POTS, or postural orthostatic hypotension, and dysautonomia. And fortunately, we now understand more about these mechanisms, and there are a couple different tests available to be able to help clarify that diagnosis.
Thank you. This one says, my daughter has pain all day, but when she lies down, it minimizes to 0. So what is the relationship between pain and being in a horizontal pose? What about opioids?
So there's a lot of different mechanisms that can activate and exacerbate pain. And so sometimes, so some individuals find more pain when they're standing up because of kind of the different pressures on the joints and the different mechanical forces that happen when you're up, or different kind of extension or flexion of joints. And so if there's more pain when you're standing up, that would be something to talk to like an interventional pain doctor or a physiatrist about, to see if they can understand like what nerves could be damaged or injured. And also to think about any type of effects on the spinal cord, like a duralectasia as well. Oftentimes people have the opposite experience when, especially at nighttime, when they're lying down and they start to have more pain. And that's oftentimes because you're not doing as many things and your body has more time to start to tell you that you're in pain.
Okay, great. So there are lots of great options for pain control here that you presented. Where would somebody start if they're wanting to explore the idea of addressing their chronic pain?
So in terms of finding that quarterback, sometimes it involves who's available in your area, right? And so who's available based on your insurance and in the area, or where you're able to travel to see a specialist. So sometimes primary care doctors can be really helpful in terms of talking through some of those strategies, and they might even know the different pain experts in the area. Many people probably have access to interventional pain, and that can be a helpful place to start to, because they're going to possibly get some more imaging and do a thorough workup. If you feel like there's a component of not really enjoying things in life, with difficulty sleeping, and you've noticed a very, not necessarily even a very obvious, but a shift in kind of your general functioning, that might be a reason to say, maybe I should go towards the behavioral health and see someone who's a therapist or a psychiatrist for pain management first.
Okay. So what would be good ways to advocate for yourself with providers when they dismiss your pain or only tell you to take NSAIDs, but you don't want to take opioids?
Yeah, I get this question, I think, every year. And in general, what I suggest is bringing a list of ways that the pain is affecting and impacting your quality of life. So unfortunately, we've really, for a while, had narrowed pain down to that numerical rating scale of 0 to 10, where's your pain, and then trying to manage pain through a scale. But that doesn't really describe the impact of pain on a quality of life. So sometimes I ask people to go talk about how it's affecting your sleep, how it's affecting your inability to take walks or go on hikes or engage in activities, and kind of make it a little bit more relevant to what that other provider might be willing to kind of discuss or engage in. And so hopefully when they hear more than a number, they're willing to say, okay, let's talk about different strategies. And, I think hopefully providers are changing their attitudes and appreciating that pain is real, especially now that we have more objective measures to look at pain. But if you really feel like that provider is not listening to you, and if you're in a situation where you can switch providers, I would say to try to find a new primary care, or try to find someone who could be your quarterback instead of that person.
Mm-hmm. Could you talk about injections and stimulants?
So I didn't mention it too much, other than that they exist. What I would say is that, I also kind of throughout the year, I'll get questions about the evidence for people with connective tissues and injections and stimulators. And there honestly haven't been high quality trials specifically for Marfan or VEG or low steats. But I know that they can be really helpful for different individuals. And so different interventional pain doctors will be able to, based on imaging, like an MRI, would be able to consider if they think some type of injection that essentially kind of numbs the nerve or helps reduce the inflammation of a nerve, typically one coming off the spinal cord, could be helpful. We are in a phase of medicine where spinal cord stimulators are becoming very popular as a recommendation. I think there's some concern that we might end up using them too frequently. But I think it's important to have a discussion with your local doctor about what are the risks and benefits. Some of the benefits are that it can really stop and tune down that pain. Another risk is that it's a foreign body that can have other challenges, and then that also, which might not be as a priority down the road, but it can affect your ability to kind of get further imaging or other types of stimulators down the road. But I think it's a very individual discussion with your local provider.
Thank you. I'm not sure if you know about this program, but it's called the Empowered Pain Relief Program through Stanford with Beth Darnell. Just wondering what you thought about that type of program.
Yeah, Beth and I have given many talks together, and I'm very familiar with the Empower program. she's doing a great job in terms of bringing more pain education to a general public. And I think that program can be really effective in terms of kind of providing a level of pain education that most people don't get. And a lot of different pain tools, kind of similar to what I was talking about here about cognitive behavioral approaches, and different relaxation techniques. A lot of the patients in those studies are individuals who kind of have some moderate levels of pain. It might not be as complex as someone who has a connective tissue disorder, but I think it's a great resource. And but also, if it's not effective, just that, to don't give up hope and continue to try to find some other strategies that are more individualized as well.
Mhm. So you mentioned numerous different top doctors in the beginning that could help with different types of pain. This one question is asking, would a psychiatrist be the best for pain management medication?
So I'm biased and I would say yes. So similar to what I mentioned, if you go to a surgeon, they're going to want to operate, right?
Right.
But I think the benefits of psychiatry are that we really, as a specialty, think about the whole person. And so we're really thinking about what a mental health disorder someone might have, but also what their personality vulnerabilities are and how to use that to one's advantage, or how to kind of stop and kind of and reframe some of those vulnerabilities. We're going to be specialized in substance use and also kind of through other life experiences. And also, I mentioned those medications for chronic pain are actually the ones that psychiatrists get the most training in. So a lot of physicians in primary care and other types of pain, they're familiar with, okay, I'm going to try duloxetine. We're going to go to this dose, and if it doesn't work, then we'll try a different medicine. Psychiatry, we have a much broader understanding of how to combine different medications and potentially even kind of increase doses. So I tend to see a lot of patients who end up on a low dose of a medication. And as I start to increase the medication to a more therapeutic dose, they actually say, oh, this medication is actually helping me. And so those are some of the reasons that I really support psychiatry as a specialty. To be fair, I'm at Johns Hopkins, where we actually have a whole pain psychiatry program. And so you do want to make sure you have a psychiatrist that has had some training in pain or is really willing to use our medications kind of to address pain as well as other mood disorders.
Yeah, that's very helpful. Thank you. And one other question. There are a number of people that cannot take NSAIDs for different reasons. They are, not recommended for vascular Ehlers-Danlos. Other people have gastric bleeds. What other options are there maybe for, over-the-counter type of drugs there?
So, the go-to is going to be acetaminophen, which can be helpful for pain. I will say that there is literature that shows that 1,000 milligrams of acetaminophen taken at one time can be just as effective as a low dose opioid. Now, acetaminophen has its own side effects, especially in terms of potentially damaging the liver. So even if it's over the counter, you really need to talk to your primary care doctor or local doctor about what you're using over the counter and make sure that it's safe. There's also some muscle relaxers that I didn't really go into, some of which have side effects and can affect how we think, and like a fall risk. But one in particular that I oftentimes educate is called methocarbamol. So it's not addictive. It can help with muscle relaxation, and there's a lot of different dose variations that you can try along the way. And then there's sometimes even some of the antihistamines, while they don't directly target pain, they can help take a little bit of some anxiety, which can help with the pain overall. Again, you have to talk to your local doctor, even if it's an over-the-counter or a supplement. I know 30% of the people in our country take supplements. It's really helpful that your doctor knows that, because those supplements can interact with your other medications. But there are some other options other than NSAIDs.
Okay. How can SNRIs help chronic pain?
So the N is for norepinephrine. And that's actually one of the main neurochemicals that regulates our pain pathway as well as our autonomic nervous system. So the norepinephrine, these medications help regulate the nerve signaling, including in our pain nerves. And so medications like duloxetine are approved for musculoskeletal pain. And then there are medications like milnacipran, which is an SNRI that's actually approved for fibromyalgia. What's important to realize is the FDA makes their approvals based on what population the drug was studied in. But then oftentimes we use medications off label all the time in medicine. So the medicine milnacipran we use as an antidepressant, even though it's approved for fibromyalgia. But at the baseline, it's because the neurochemicals that affect our mood and pain are actually the same neurochemicals.
Okay, and just one last question. I'm not sure that you can answer this, but this person thinks they may have dural and hasn't seen anyone. They don't know what to do. What would you recommend?
So usually for dural you want to look to see a neurologist, potentially an orthopedic surgeon, or a neurosurgeon, but you can start with neurology usually, because they would want to do some imaging of your spinal cord and the brain. There are some specialists around the country that use surgical techniques to treat dural but honestly, the best evidence for managing kind of pain related to dural is to use the SNRI medications and other neuromodulators. So that's something that a primary care or a pain provider could prescribe to help manage pain.
Mhm. There's also a physician over at Stanford, Ian Carroll, who specializes in dural and he has some videos online as well, information online for that. Okay, one more last question. Is some level of chronic pain ever normal for connective tissue disorders, or is it sensible and reasonable to always try to address it somehow?
So I think with chronic pain, you want to accept that there is always going to be some chronic pain, especially with connective tissue disorders because of kind of bone formation or kind of ways that the muscles are getting pulled and kind of instability and hyperextendability of the joints. But I don't think that you have to live in so much pain that you can't function or live your life. And sometimes providers say, oh, well, you have this condition, so you should have pain. And there can also be other reasons that people have pain. So there might be other things happening. And actually, I see that all the time is that we're missing diagnoses of other conditions that can cause pain. So I really encourage people to get a full workup. To make sure that people are not missing some other medical condition or problem.
Okay, thank you so much. This has been really, really a great webinar. You provided a lot of information for our families, and I want to thank you again. And we're looking forward to seeing you, all of our attendees on our other webinars that are coming up tomorrow. Actually, the next day. We have no webinars tomorrow. So thank you very much for participating and take care. Have a good night, everyone. So long.